Good morning, Sharif.
Hello, Milind. Good afternoon. Nice to join you all again.
Good to see you, Sharif. Do you just want to try screen share for a second?
Sure.
Yeah.
I think we're good.
No, we're good. We're good.
Okay, so let me stop the share. Mhm.
I think it's just past 5 here, and it's just about 11 o'clock for you, Sharif. And we will start. Can you hear me nicely, Sharif?
Yeah, I can hear you very well.
You can hear me very well. Huh? Okay, 1 second. Good afternoon, good morning, good evening, and probably good night for some of my friends. And I welcome you for the Zoom academic meeting of the Department of Pediatric Surgery in East London, Eastern Cape, South Africa. And today we are going to discuss transitional care in pediatric surgery. And we are really honored that Professor Sharif Emil is invited guest for this talk. And I don't think most of us need any introduction to Professor Emil. But in addition to being a professor of pediatric surgery in Montreal, he is a very dear personal friend. For those who do not know him, he was born in Egypt, studied and trained in USA and Canada. He has conducted various missions to Africa. He uses social media for education very nicely. I'm learning from him, and he likes to share, and he loves to teach. So Sharif, we are really honored to have you with us today. And what has happened is Dr. Nayha Gautam, our registrar medical officer, has prepared the topic. She actually did a lot of reading and has prepared the presentation. But unfortunately, we are so short-staffed that work-related stress has resulted into her developing severe laryngitis. And she has been advised strict voice rest for at least a few days. So I'm going to present on her behalf, but please bear with me that this is not a presentation which I prepared. So I have tried to learn it as much as possible, but most of the credit goes to Dr. Gautam. So without further introduction, I will start with the presentation. Can you see my slides, Sharif?
Yeah, I see it well.
Okay, good. So we will cover this topic under these headings. And transition of care refers to the process whereby adolescents and young adults with chronic surgical and medical conditions are transferred from child-centered to adult-centered healthcare systems. The objective is to provide continuous and uninterrupted healthcare appropriate to the developmental age of the patient to maximize lifelong functioning. Transition programs help to improve follow-up and result in better control of acute and chronic complications. The benefits of transition of care models have been substantiated in various medical subspecialties, including pediatric cardiology, spina bifida, organ transplantation, and pediatric surgery units, including adolescent urology. Significant advances in medical science, practices, and technologies have resulted into an increased survival among infants with conditions such as esophageal and bowel atresia, anorectal anomalies, Hirschsprung's disease, and other pediatric surgical conditions. Currently, more than 85% of children with chronic conditions survive to adulthood. These high rates of survival mean that increasing numbers of adolescents confront the issues, questions, and barriers of transitional care. In addition, the shift from institutional to community-based, family-centered care has increased the importance and public recognition of transition. Transitional care of patients spreads across all surgical and medical disciplines like cardiothoracic surgery, general pediatric surgery, neurosurgery, pediatric urology, cancer, and organ transplant survivors. The optimal goal of transition is to provide healthcare that is uninterrupted, coordinated, developmentally appropriate, psychologically sound, and comprehensive. Most importantly, transitional care is a multidisciplinary function and not the just doctor's responsibility. In a 10-year audit of admissions of young adults aged 18 years and over to a major pediatric unit in Australia, 51% of surgical inpatients and 28% of medical inpatients had no documented plan for transition to adult care. But when individualized transition plans that were developed with the young people and their parents were implemented in a program of transitional care, they were successfully completed by over 95% of adolescents and their parents. This confirms the need for individualized plan of transition. Although transition of care is practiced in many developed countries such as USA, Canada, UK, and Australia, its usage in developing nations is still in its infancy. It's a concept that still faces significant challenges and difficulties. While healthcare providers in this region agree on the need for transitional care programs, actual transition of care guidelines are neither established nor developed. In developing countries like the ones in our Africa, many young adults are often still admitted to pediatric care, most likely due to disease complexity, failure of transition planning, and the lack of appropriate services within the adult healthcare sector. These observations show that the implementation of transition of care procedures can be challenging worldwide and require careful planning and consideration. This results in pediatric surgeons caring for adolescent patients well into adulthood and their eventual transfer to adult care occurring in an abrupt, disorganized, and ad hoc manner. So what are the factors to consider? The breakdown of care between child and adulthood is therefore a multifaceted and multi-level problem. Fault lines may occur at several levels between the child and adult, social, healthcare, and welfare services due to financial constraints, complications, or psychological factors. Transition of care includes primary, secondary, and tertiary healthcare facilities, healthcare professionals, young people, and their parents. A failure to address these faults may mean that any gains made by children's services are undermined or lost and more importantly, that young people and parents experience unnecessary distress. This diagram illustrates factors that are influential in the transition from child to adult care. So how do we prepare for this? The first step in preparation is helping the patient understand that transfer of care will eventually happen. Adolescents are more likely to take ownership of their chronic medical condition when they perceive a shared management between themselves, their parents, and their healthcare providers. Whether there are one or multiple options, the pediatric provider should prepare appropriate documentation and facilitate orientation and introduction to the adult practice and key team members. This approach has been shown to increase a patient's sense of security. Self-management and ownership of your own health are very critical and important concepts. Many of these patients will need assistance from a developmental specialist as well. Specific details need to be individualized for each patient. Now, what is a transitional care model? In that, identify a transition team leader, ideally a transitional care coordinating nursing sister. Institutions need to identify and design their own guidelines for transition and develop protocols. Health education is very important. Patients with more knowledge about their diagnosis demonstrate better understanding of transition to adult care. Many centers recommend keeping all the required information in a health passport. Now, how does actual transfer happen? This plan will include competencies that need to be achieved by patient before transfer. This is called transitional curriculum. The provider who will take over management is identified. Meeting the new provider together with the pediatric provider, proper documentation, and choosing a specific time to have the transfer. It is important to identify and remove barriers to transition of care. There are numerous people involved. The patient can become overwhelmed navigating the system, leading to his or her unwillingness to participate in the process. This can be dealt with by parental care, because parents also need education and counseling. Children can get their support through support groups and various online resources. The role of pediatric surgeon is critically important. Healthcare providers play a crucial role in promoting gradual self-management. Success in the transfer is directly related to pediatric specialists recommending the transfer and patients' belief that care should be transitioned. Studies have shown that adolescents consider it normal to leave pediatric specialties when they reach adulthood. So they want to go and get treated by adult practitioners. It is important to address patients' fears. Patients may have fear or anxiety of seeing an adult provider. Patients report a feeling of the adult system being less nurturing, busier, and more complicated. Studies have reported that patients are more likely to attend follow-up with an adult provider if they were referred by pediatric provider. Patients feel reassured when their pediatric providers show trust in the adult care providers. To strengthen this relationship, both adult and pediatric providers should be involved in creating the transition program, which includes monitoring of patient follow-up. policy on timing of transfer to adult care at age 18 or leaving school is recommended by many experts. A preparation period and education program that focuses on the set of skills that enables young patients and their families to function in an adult clinic is necessary. These include understanding the disease, treatment rationale, source of symptoms, recognizing deterioration and taking appropriate actions, learning how to seek help from health professionals, and how to operate within medical systems. A coordinated transfer process, including a detailed written plan and pre-transfer visit to the adult clinic with an introduction to the adult provider and with a designated coordinator such as a clinical nurse is ideal. It is essential to have an interested and capable adult transitional care regional center that is at least equivalent in quality to that of the pediatric center the patient has received care so far. Transfer is planned and carried out during a period of medical stability. After transfer, ongoing consultation between the multidisciplinary team is essential. Transitional care model has 4 concepts. The first is administration or admin. First, identify a reliable general surgeon who understands the condition and its long-term management. The resources which are there, like the patient should be followed up in an area which is closer to their home. We need to find out, do they have transport to go to that place? Does the department responsible to take care of that adolescent have the resources to support the patient? Do they have the medicines, consumable, equipment, etc.? The second step is preparation. Evaluate the readiness of the patient. Do they require further education about their condition? Promote self-management and guide the parent to let go of the child to take ownership of their illness. And in many children who have been chronically ill, that could also be a problem for the parents to let go of the care of their loved ones. Third is to prepare a plan for transfer of care. Appointment dates are necessary, and it is important to have a couple of appointments together with adult caregiving team. We need proper documentation of the illness, what investigations have been done, what medical and surgical management has the child received, the surgical notes, complications, what is the long-term management plan, what is expected basic minimum treatment, all needs to be written down. The fourth point is follow-up. And follow-up, you need to promote follow-up, emphasize the importance of management of the condition beyond adolescent and into adulthood, and emphasize to the child and to the family that follow-up with adult provider is quite important. Now, we are just going to have some case studies, and my senior colleague who is here, he will probably recognize most of these patients. And I think Dr. Carla van Reesburg is joining from, I suppose, Northern Ireland. She will also recognize at least a couple of these children. So this is a young lady now, 24-year-old. She is known to have an incurable disorder, functional disorder of the large intestine, African degenerative leiomyopathy. We diagnosed her when she was about 7 or 8 years old, and we inserted a button colostomy for her to deflate her colon and give antegrade colonic enemas. Now, many years later, she is mother of 2 beautiful daughters. She lives in Cape Town, 1,000 kilometers away from East London, in much bigger city, but still battles to get basic replacements, basic things like replacement of these Mickey buttons. And believe it or not, 3-4 months ago, she had to travel all the way from Cape Town to East London to get an appropriate size Mickey button. That is because we could not find a proper, let me not say proper, we could not find an appropriate adult caregiver who could look after her to her satisfaction. The next patient is also about 24-year-old. She was born with bladder extrophy, and between state and private institutes between East London and Cape Town, she underwent multiple operations, starting with functional bladder closure, then bladder neck closure, augmentation cystoplasty, Mitrofinov, appendicovesicostomy, and sigmoid colon augmentation cystoplasty. Due to continuous secretion of mucus, she kept on developing bladder stones. So this is an image of a contrast study done more than 10 years ago, which shows that her bladder is almost like a bivalve bladder, and there are big stones on either side. And due to these stones, she develops repeated urinary tract infections, almost once every 2 months. And initially, we operated on these bladder stones and took them out, but she continues to develop more bladder stones, and she's so fed up with operations that she has elected to live with these stones in her body and repeated infections and repeated antibiotics than having to undergo more operations. Next examples are quite heartwarming. The lady on the left-hand side is also about 22 years old, and you can see that she has lost both lower limbs. She was born with spina bifida, luckily didn't have hydrocephalus, so had obviously neurogenic bowel, neurogenic bladder, and developed so severe pressure sores that she needed hindquarter amputation on one side and sort of upper thigh amputation on the other side. But she is so clever. She's completing her university. She intends to become a human rights lawyer, and represent her province or constituency in the local legislature. The second young lady also was born with spina bifida, has had multiple surgeries, and elected not to have continent urinary diversion. She prefers to have do clean intermittent catheterization and once or twice a day bowel washouts. But she comes from a well-to-do family, highly educated doctor parent, and she has really done so well that she is now sort of designing clothes for physically differently able people. So these are very heartwarming examples. So in conclusion, what I would like to say, that transitional care, as with the rest of adolescent health, is now firmly on the health agenda. Further successful development in this area will require a shift in attitude and a bit of passion from health professionals, along with mutual respect and effective collaboration between pediatric and adult care providers across disciplines and professions in health, and across the agencies representing education, social services, youth services, and the voluntary sector. Transitional care is an individualized approach to each patient. No model is superior or shown to be better. However, the one which we have provided gives you a basic platform how to go about transitioning a patient to an adult healthcare provider. I would like to conclude this talk by a final statement that we must get transition right so that it becomes a positive, enriching experience for all young people with chronic illnesses and or disability. Thank you very much. So I have actually presented on behalf of Dr. Nayha Gautam. And now I invite Professor Sharif Emil to share his views and give his opinion and advice. Sharif, please continue.
Okay, thanks so much, Milind. That was really great. And thank you, Nayha. I'm sorry you lost your voice. That means you're doing a lot of talking with patients. So thank you for doing that. Yeah, so Milind contacted me maybe 3-4 weeks ago and asked if I could suggest a pediatric surgeon who has expertise in transitioning care. And I said, well, I wish I knew somebody because I would really want to talk with them. And I certainly am not. So I want to just give a real disclaimer that I'm not speaking here as an expert. I'm really just sharing our experience and some of the things that are happening in North America with you. And I would also like to say that it really is a severe challenge for us. Despite resources, we have not gotten this right, and we are still struggling. And in fact, if you look at our hospital, in the picture you see here on the right, there's a Shriners Hospital in blue, which is an orthopedic hospital for children. This large unit here in yellow is our children's hospital. And then we have a large adult hospital called the Royal Victoria Hospital and a research institute and some other facilities. And you would think in an institution like that, it should be pretty easy, right? Because we're all on the same campus and transitioning should be pretty straightforward. And yet it still is a very significant challenge. I think the one encouraging thing is that we do have a task force that is really working on this. It is definitely high on the agenda of the hospital, but we really are still very much struggling. So what is the reality? Well, if you look at the US population of about 300 million, there's about 500,000 children with complex medical condition that reach adulthood every year. So we're talking here about a very large population of patients. And at least 60% of these, and that's pretty conservative, but at least 60% do not have a structured transition plan. So this is in a quite a high resource environment. What I think we've also come to understand as pediatric surgeons is that many diseases that have a good prognosis may not be so good. And just think of Hirschsprung disease. You know, we often think if a patient gets surgery early and is doing well during the toddler years and even maybe into the late childhood, they'll be fine. But as we do more and more long-term follow-up, we find that many of these adults continue to have issues with bowel functions, continue to have soiling sometimes, constipation. They really are not a good prognosis as we think they are. And same thing applies to esophageal atresia and some other, many other congenital anomalies we treat. So as a medical community, we still really have yet to systematically consider and address the needs of this population. I don't think we are really meeting this as we speak. And again, one encouraging thing is that, you don't know what the problem is until you identify it. And there is a fair amount of literature in our pediatric surgery field. A lot of this has concentrated on Hirschsprung disease and intrarectal anomalies, understandably, because again, as we mentioned, many of these patients will continue to have issues. And there is a large amount of literature on patients with urologic congenital anomalies, especially urologic, I think. But really in our field, in our immediate field, those seem to be the significant conditions. And these papers say different things, but the common denominator is basically they're all saying that we have yet quite a ways to go. We're still not doing really an ideal job for any of these. And these are all sort of recent publications. And there's even been publications on other entities. For example, coeducal cysts, some of the things we don't particularly think may need transition to care. And looking at these patients, there's still a significant percentage who will continue to have issues with biliary dilatations, maybe cholangitis, et cetera. Obviously, biliary atresia is a significant condition that continues into adulthood with a need potentially for liver transplant and continued treatment of liver insufficiency, portal hypertension, et cetera. So on a very personal level, I came here a little over 12 years ago. I had a pretty, elaborate plan for many new programs, and we've been very fortunate to put most of these together and really see them grow. But one of those projects was what I envisioned would be a McGill Pediatric Surgery Graduate Clinic. And knowing that we're moving into this hospital where we are now, I thought it would be ideal. And the idea was to have a clinic run by a pediatric surgeon and an adult surgeon, and to really attend to patients who graduate from pediatric surgery, if you will. And unfortunately, this just was not possible. And I learned a lot of lessons in the process of why something like this was going to be quite difficult. So what are some of the barriers? Well, Milind just went through Nayha's presentation on some of these, but maybe just to mention a few others that may not be so intuitive. First of all, adult surgery is far more specialized than pediatric surgery. And I think that applies pretty much in all environments, even in environments, lower resource environments where surgeons do a lot more and maybe a bit less specialized. I think that there's still a huge difference between what we do and what our adult counterparts do. So in our environment, patients that we take care of, if they really need a surgeon as they become adults, they may need a surgical oncologist, a thoracic surgeon, a hepatobiliary surgeon, a colorectal surgeon, even a gynecologist, among others. So it's pretty much impossible to have a single program where one or two or even three surgeons on the adult side can inherit the patients we take care of as pediatric surgeons. Another barrier is that in general, surgeons do not like to inherit patients. They like to follow patients they've operated on, whose anatomy they are comfortable with, whose procedures they know. And, just think of ourselves on a very honest basis. We will take care of patients of other surgeons when the need arises, but I don't think any of us goes out and tries to recruit patients that have been operated by other surgeons. And the other thing is that many pediatric surgical patients who need to be transitioned may not have surgical issues. I mean, think of patients who have, for example, congenital diaphragmatic hernias and may still have some lung issues, or patients who may still have some incontinent issues after anorectal anomalies. I mean, there's really, in many cases, no further surgical work to be done. Now, we love taking care of these patients because they're our patients. We operate on them. We are dedicated to their outcomes throughout their life. But it's easy to understand why an adult colorectal surgeon may be reluctant to inherit such a patient who they will not be operating on, and they just need to participate in bowel management. And then finally, familiarity. There's been a lot written, for example, on Malone procedures and the lack of familiarity with a lot of adult surgeons of these, and really patients being orphaned when they have a antegrade continent enema procedure, a MACE or a LACE. There can be some financial motivations. Again, surgeons often may not want to inherit patients that don't have a surgical potential. In addition, certainly in the US, not so much in Canada really at all, in many Western countries, but in the US, children's insurance is usually quite universal. It's rare to have a child who's not insured, but that can change when they become adults, or they may still be insured, but the adult surgeon may not accept the type of insurance that the pediatric surgeon was accepting. So there can actually be some financial barriers. And then Milind also talked about this. And yes, there can be patient and family reluctance, a fear of the adult environment. And that fear is not completely irrational, right? Because I think we can all admit that our environment is quite different from the adult environment. So this is a sort of a position paper that was published in the American Academy of Pediatrics by the American Academy of Pediatrics a few years ago. And it's not very comprehensive, but I think it is useful because it does lay out some of these challenges and also some potential for how to move forward. The other thing is that a lot of the advocacy groups, for example, the CDH group, the tracheoesophageal fistula group, the pull-through network, they have really been very vocal in arguing for effective transition of care plans. And so I think partnering with these advocacy groups in your local chapters and so on can be very, very helpful, or even on a provincial or a national level. And there needs to be a significant assessment of what really is the need. What is the patient volume that needs to be transitioned? Not every pediatric surgery patient who had a congenital anomaly repaired may necessarily need transitioning. And therefore, what are the specific medical issues? It's not enough to say, okay, this patient's now 18, I've been following him throughout their life, or a pediatric surgery team was following him, now he needs surgical follow-up. But what do they need to be followed up for? And what is actually the long-term follow-up? So again, if I'm going to transition a patient, how often does that patient need to be seen by the adult team? Is it enough for a surgeon to see them maybe once a year, etc.? There's many guidelines now we use. In our practice, for example, we use the AAP guidelines to follow CDH patients in our CDH multidisciplinary clinic. The AAP doesn't really have guidelines for adults, but those guidelines can be conformed to adults in some ways, maybe depending on the severity of the symptoms once the child reaches adulthood. And the transition needs to be formalized in many ways. And it shouldn't be really a sudden transition at age 18, where one day you're at the children's hospital, the next day you're at the adult hospital. Ideally, it should really be gradual, and probably starting at 16 and gradually transitioning at age 18 is most likely ideal. And of course, having the appropriate resources is important. We do have some examples of success. So if we look at congenital heart disease in our environment, that has been quite successful. Now, again, I think it's helpful to dissect why it's successful. Well, because many of the congenital heart surgeons also operate on adults with congenital heart lesions. So many of these surgeons are not pediatric cardiac surgeons, they're really congenital heart surgeons, and they will operate on a congenital heart anomaly, whether the patient is a day old or whether they still need another stage procedure into their 30s. So that continuity is very, very useful. In our practice, we have a very successful transition of inflammatory bowel disease patient. We have a large population of these patients, and we have a transition. Now, in that transition is successful because it doesn't work through surgery. It doesn't go through pediatric surgery. It really goes through the pediatric gastroenterology into the adult gastroenterology. And for a long time, we actually had an adult gastroenterologist who is very interested in inflammatory bowel disease in general, be on service in our hospital, and he unfortunately passed away a couple of years back, but it was really a seamless transition because he was already familiar with many of these patients. Nevertheless, the transition still is quite straightforward, quite smooth, because it's a built-in, well-structured transition of these patients who obviously will need chronic care. And obviously, solid organ transplants. Again, why is that? Well, because in many practices, it's the adult transplant surgeons who come and do the solid organ transplants in children. That's the case in our practice, for example, because there's just not enough of them for one of us to be doing the kidney transplants. So the transplant surgeons come across the hall from the Royal Victoria hospitals, and they do the solid organ transplants. The children still remain, for example, under the pediatric nephrologist. But again, the transition is quite seamless because of the continuity of involvement of certain practitioners. So these are really examples of success. I think the question we really have to look into and really have some introspection about is what should be our role as pediatric surgeons. And some of this is sort of global in terms of looking at the big picture, if you will, but some of it is very local, is very personal. And that's really how I often like to think about it, because once again, it really comes to one patient at a time. And what do we need to do for each patient, maybe in the absence of a structured transition or in the absence of a infrastructure that allows us to do that. So the pediatric surgeon really I see still as the anchor. And for many of these patients, even who do not have ongoing surgical issues, I think we can all agree that the pediatric surgeon is really their primary practitioner. The neonatologist who may have treated the baby does not follow them. The pediatrician who may have been seeing the child was not familiar with their congenital anomaly, did not attend to them as a baby. Really, it's the pediatric surgeon who is the link. And this is what I mean by the anchor. Really, the link in clinical care and evolution of the case is the pediatric surgeon. And education is very important, as I'll show you a couple of cases in a minute. Like a lot of times when patients end up in adult care, that lack of familiarity leads to unnecessary interventions, unnecessary conclusions. So it really behooves us to educate our adult colleagues about what we did, what the issues are, and what are the potential issues that may arise in the future, even if they're not issues at that point. And documentation is really critical. So, for patients who graduate and go on to see adult practitioners, I think it's really essential, even with an electronic medical record when one is available, not to count on that. They need a crisp summary of their course, so somebody could read that in maybe 10 to 15 minutes and really understand what was done and what are the current issues and maybe what are the potential future issues. And it's no different than providing that to a patient who's moving from, province to province, state to state, country to country, etc. And, I think that that's very, very useful. So often I make sure that the future physicians have all my contacts, have documentation of what was done, have a summary that the patient has in their hand that they can actually provide also on the spot if they end up in an adult facility emergently, for example. And we need to do, again, what we do all the time, and that is to advocate. So many times on a case-by-case basis, we have to negotiate the adult healthcare environment on the patient's behalf because it can be extremely intimidating. So I've often gone with patients who are 20 or 21 just to be with them during their operative experience when they're undergoing an adult procedure. I don't necessarily scrub, but I think my presence is very reassuring to the patient. And that's really part of our legacy to those patients. And again, surgeon-to-surgeon communication is extremely important. Despite documentation, if a surgical procedure is going to be needed, I think that's really critical. Another aspect is the partnership. So one, again, a successful model we're currently employing is for patients who have familial polyposis and use an ileoanal and need an ileoanal pouch procedures. Again, we know that many of these patients continue to have issues with their pouches over time. And we used to do all these procedures ourselves. And then we concentrated really in the hands of one or two surgeons within our group because, again, the volume was a bit of an issue. And what we do now is we invite the same colorectal surgeon, adult colorectal surgeon, to come in and participate at the Children's Hospital in every ileoanal pouch procedure, which means that when that patient becomes an adult, which is typically within a couple of years, because most of these are done during mid to late adolescence, the surgeon who participated already knows them and again has a relatively seamless transition to the surgical follow-up. And then really what is sometimes a challenge is for us to provide adult care. And some of my colleagues are very uncomfortable with that, but I certainly make myself available. And again, I'll show you examples of some patients just very recently. And this sometimes can be in partnership, ideally with an adult surgeon, but sometimes may not be. So here's a case I had a few years ago. It was very interesting. A 29-year-old man who had a jejunal atresia at birth was in the hospital for 2 months, although his family had forgotten that, and then eventually did well. And in his late 20s, he was running a successful business, doing quite well, but started getting obstructive symptoms. And as many of these adult patients go through, when there's not a discussion with a pediatric surgeon, when there's not a review of their pediatric trajectory, the patient was diagnosed with a stricture anastomosis, which of course made little sense for something to stenose, 20 some years out. And then that was revised and then had multiple lists of adhesions. And when was diagnosed with pseudo obstruction, he eventually had a permanent gastrostomy and was on TPN. I mean, really like very invasive treatments. None of them were successful. And I just happened to be giving grand rounds on congenital intestinal obstruction. And the chair of the department said, oh my gosh, I think I've just referred the patient for a second opinion who seems to have what you're talking about. And I was talking about latent jejunal and latent duodenal obstruction, which can happen very late. So we assessed the patient and we figured that that's really what the problem he has. And here you can see that the proximal jejunum is massively dilated and empties very poorly. And he had a huge mega jejunum that developed over many, many, many years. There was no stenosis as expected. So we resected most of this dilated jejunum. We tapered the last 15 centimeters to a ligament trites. We did a primary anastomosis, and this partnership resulted in the adult surgeon being able to continue to follow this patient and give me follow-up that then I was able to use to help other patients. And it's interesting because, so we published our series, and I think this is something, it's really important that when we have these adult patients who are still disabled because of congenital anomalies, we really need to find a way to share that knowledge, not in our pediatric surgical literature, but in the adult surgical literature. And this is a paper that was seen by another surgeon just in the last couple of months, managing an almost identical patient, and then was able to contact me, and I actually will be operating on a very similar patient this coming Monday. Now, here's something that just happened last week, and I thought this is a bit serendipitous because we were just about to talk about this. So this is a 20-year-old man who had a NUS procedure at age 17. And we do a very large number of NUS procedures here because we have a very busy chest wall center, and did super well. Follow-ups were completely normal. We are very fortunate through one of our children's hospitals that we were able to see these patients until age 21. So usually by then their NUS bar is removed and there are really no ongoing issues with their chest wall. But this young man came in because he was having chest pain, and the chest pain worsened over several days. He started becoming very short of breath. So he went to our adult hospital because he can't come to the emergency room at the children's hospital, only at the Shriners for elective care. And he had a bedside ultrasound that showed some pleural fluid, and then went on to do a CT scan that showed this very large pleural effusion on the right side. And what was called, and you can see these green arrows here, a pleural tumor. So he was worked up as a patient who's presenting with a new pleural tumor resulting in a pleural effusion. Now, obviously, from a pediatric standpoint, having followed this young man and having seen his chest x-rays recently and so on, it made no sense that he would present like that. So I called into the adult emergency room, and you know, they weren't super receptive at the beginning because, like, why is a pediatric surgeon calling in? I explained to them that I think I can help because I did his surgery, I know his anatomy, and that this is not likely to be that. So they were ready to contact the thoracic surgeon and get IR to biopsy this, and it just really was going to be a sequence of events that I think was going to be unfortunate. So we got special permission to transfer him back to our children's hospital. And the diagnosis in this young man, which I suspected, although I've never seen it before, but you know, I had reviewed it and I had read about it, was an erosion of the bar over a long time. Again, it was 2 years after surgery, through either the internal thoracic or intercostal artery. So we took him to surgery. And of course, the pleural tumor was just a huge clot. You can see it here with the clot removed. So we had a scope. With the clot removed, we could see the bar and we could see the erosion around the bar. And under direct vision, we removed the bar and we were ready to control hemorrhage if needed. So we really had to intervene to make sure this young man gets the right intervention and does not start into a cycle of events that may have been appropriate for an adult presenting like this for the first time, but not for a pediatric surgical graduate. So to summary, and this is really, again, just my perspective, I don't think we can have any such thing as a pediatric surgery to adult surgery transition because of the diversity of patients we take care of. So any transition has to be disease-based and programmatic. That may be through surgery or through medical specialties or both. Ideally, it should be gradual. And ideally, if an adult surgeon is involved early on from the first interventions, that really facilitates the gradual transitions. And ideally, they should be provided in institutions like ours. We have the perfect setup because we provide cradle to grave care. It's much more difficult if the patient is in a freestanding children's hospital and they have to go to a brand new institution. We need to outline exactly what the issues are and to have clear algorithms for our adult colleagues of what and how often they need to follow these patients. And of course, advocacy, advocacy, advocacy. So again, I would encourage all my friends in East Africa to contribute to CB Clips. We're now starting to have guest presenters in a program that I'm very excited about. And I know you have tons to teach, so please consider contributions, and you're welcome to contact me if you'd like to be a guest presenter. And I want to thank you from our team here.
Thank you, Sharif. I think that was quite useful. it was sort of building on what Nayha had prepared and what I had presented. So that's, I think you have put the facts down, and we do not have proper transitional care program, but we need to work towards it. And I think these young adults, they have so much trust in us that you would agree that, at least to me, many of these young ones who are around 24 or so, they contact me for anything and everything. Because I have seen them, they have seen me since they were babies, and we grew together. And even sometimes they ask my opinion and advice about their personal decisions, which actually just shows how much faith they have in us as pediatric surgeons. Now, I would just need to invite comments. I think Professor Hadley is still here. Professor Hadley, please give your comment.
Hi, Milind. Oh, if only we lived in a perfect world, but we don't. We have to transition our patients out. When I was working at King Edward, we transitioned them out at the age of 12 because they weren't allowed in our unit. After that, we didn't have space for them. And what you've both alluded to, both of the speakers, is the importance of having a receiver who understands what the hell is going on. And I can't help but think that we've missed a trick here in South Africa, because back in the day, you couldn't become a general surgeon unless you'd done some pediatric surgery, but now we've waived that condition. You couldn't become a pediatric surgeon unless you'd done some general surgery. We've waived that condition. So people on the receiving end of this will have absolutely no idea what you're talking about. And taking the example of Hirschsprung's disease, which we all know is a lifelong problem, but the person who needs to identify these lifelong problems is the surgeon who did the procedure, not the general surgeons to whom he's transitioned the patient. So I think personal follow-up of an operation is very, very important. And I would hate to think that people in adult surgery with limited experience of pediatric surgery were managing the complications of surgery that I'd done. And I'd much rather take responsibility for that myself. So yes, I accept that in an ideal world, what has been proposed is absolutely first class, but it's impractical, I think, in the environment in which I've been working, well, up until a few years ago, and I suspect will be difficult to implement in most practical situations in certainly East and Southern Africa. I'd be grateful to know what you think.
Sharif, do you want to comment?
Yeah, no, I completely agree, Larry, and honestly, I don't think, I mean, the problem may be more difficult and more acute in your environment, but it's a real challenge in our environment also, and also just actually even identifying the cohort. I see a comment on the chat about, you know, patients often are lost to follow-up even as pediatrics, so as pediatric patients, so they don't often graduate to adults. And the question begs itself, I mean, who do we need to follow? I mean, if you look at Dr. Peña's contribution to our field, one of his largest contributions is not just the Peña procedure and the PSARP and really, but it's the follow-up. Like, he made a point of following all his patients. So he, you know, he came and operated with me both in California and here, and he would keep a little sticker, even though it's not his practice, and he would get updates on those patients. So this is amazing. And you know, we don't often do that. If patients don't come, we assume, right, that they're doing well. And that may not always be a good assumption. So I think the issue is for us first to understand really who is it that we need to transition. And it may be that the most ideal in a regular world, the most ideal situation in a non-ideal world is to really transition on a case-by-case basis. Those patients who really truly need ongoing significant care, to identify practitioners who will see them and help them transition to those practitioners. And that may be the best practical solution.
Sharif, I think I can just coin both your advice and Prof. Headley's advice. That is what I have done in my practice. I had two more examples, which I didn't share due to limitation of time, but exactly we need a willing receiver. And once I identified a willing receiver, only then very gradually I transitioned those patients to those surgeons, still keeping communication links open to me if they needed any advice on either side, whether the patient needed advice or the further healthcare provider needed advice. So I think those both points are essential and important. I'll just ask now Dr. Selo Machaya, who is our consultant pediatric surgeon, and he has actually mentored and advised Dr. Nayha to prepare her talk. Selo, your thoughts?
Yes, thanks, Prof. Thanks for everyone's contribution. I think as everyone reflects, the important thing is just communication, I think is key, because you can communicate what is the expected problem in any patient. And it's worthwhile doing it patient by patient and not just saying every single patient that comes here gets grouped together in this basket and gets sent to the receiving surgeon. I think every single patient is an individual and needs to be addressed as such. And the other thing as well, we have a tendency of trying to keep the patient as long as possible. As much as we should be transitioning them, we feel that we've invested so much time, we saw the child grow and they are thriving, and we want to see them thrive further, and have a tendency of trying to say, okay, let's keep them longer and see how that goes. But that's where it's important to be able to realize that we should slowly but surely sever the tie we have with our patients. It's for their own benefits, because as time goes on, they will require, if necessary, further surgical procedures, which can be maybe at times offered better by the other treating surgeons. So I think ultimately communicating with the patient, particularly when they're old enough. Unfortunately, we still have a tendency of treating only kids up until 12. It's only rather few of them that we see in the adolescent years, but we communicate with the patient so that they understand why they need to be transitioned. They can communicate with the family, and lastly, I think communicate with the receiving doctor, because it's pointless communicating with the receiving doctor and not involving the patient, who's the important person in this equation, and the family. Because once I've had situations where the patient themselves tells me more about what's the pathology, what's wrong, than what the general surgeon saw, where you have a 15, 16-year-old patient who the surgeons have no idea what's happening, and they're like, okay, the child was managed long ago by the ped surgeons, but we're not sure what's happening. And the patient or the family themselves actually give a better record of what's happening and what was done, and can actually guide you as to how to further proceed in the management of these patients. So communication is extremely vital, and I think that's how I'm going to end it. Thanks.
Thank you, Selo. I'll invite Dr. Yashoda Manikchand, who is our other senior consultant pediatric surgeon, to share her thoughts. Yashoda.
Hi, Prof. Thank you. And thanks to all the speakers. Yeah, I tend to agree with all the points that were made. I think we have to balance it for each patient and ensure that they get the care that they need when they are transitioning into adulthood. And one patient comes to mind, Ibiwe Pony, one of our children who had an esophageal replacement, which is also something they carry into adulthood, and lots of problems from that. And we have the same challenges of not being able to accommodate her in our wards, etc. And at some point, we're going to have to say goodbye to her and send her off to an adult surgeon. And the transition is so important. The other thing I wanted to mention, and Prof. Hadley didn't, but he had a clinic, an oncology clinic, that followed patients with solid tumors well into their 20s. And it was an annual follow-up, but it was so important to them that they had that that line open to share their progress with us. And, you know, it was interesting because a lot of them ended up sharing their reproductive and sexual issues with us. So, I mean, it's an ideal world to be able to follow them up to that point, but some of those programs can actually work, even in our setting. Just wanted to mention that. Thank you.
Thank you, Yashoda. I see Dr. Nirav Patel, who is a consultant pediatric surgeon at Baragwanath Hospital in Johannesburg, is here with us. Nirav, any thoughts, anything you would like to comment, please?
Thank you, Prof. It was a really interesting discussion. And I think going back to the discussion that we had last week as well, I mean, something that we really struggle with, not only because we don't plan for it well, but also because of our patient population in South Africa, who are so difficult to follow up on in the first place. Definitely given me lots to think about how we can potentially change our practice to make sure that we ensure some continuity of care for our patients.
Thank you, Nirav. I see Carla is here. I think it is Carla van Reensburg, who is a friend of Department of Pediatric Surgery. She has experience in general and pediatric surgery in South Africa, then also in England, Australia, now in Northern Ireland. So Carla, welcome here. Good to see you. Any thoughts, any comments?
Hi, Milind, and everybody else whose names I recognize. Yeah, I just actually typed, I have to run, but I can spare a few minutes. Yeah, it's a really thought-provoking talk, I have to say, and sadly, we don't have a very good system here in Northern Ireland either. In fact, there is no system, and there's often a lot of upset between pediatric surgeons and adult general surgeons when these patients have to transition. There's certainly no involvement from the pediatric surgeons on the adult side, which is something really that, you know, we should think about and getting involved more in that way. Yes, I do think that's a huge gap, I guess, in many units, that the transitional care is not what it should be, and that I guess the follow-up care of the children are therefore potentially not as good as it can be. And I think this talk has perhaps inspired me to see how we can improve services here in Northern Ireland. So thank you very much, everyone.
Thank you, Carla. Before I get final word from Professor Emil, I just ask a quick comment from Yentle. Yentle Kamit is a consultant at Red Cross Children's Hospital in Cape Town. She worked previously in the Eastern Cape. She trained in Johannesburg and now is at Red Cross. So Yentle, any thoughts?
Hi, thank you so much, Prof. Chitnis, for the amazing platform that you've created. I think it's not only just kind of the practical and academic implications of care, but it also feels like mentorship. You know, there are people in this forum who have so much experience, and collectively it's of such infinite value that one is receiving pearls, you know, like you're almost being like tutored or apprenticed. And so I'm very, very thankful for this platform, and also to see what can be done and what is possible. At Red Cross, there is like a rather cool and unique and great partnership with the Department of Urology in terms of transition, because the consultants in urology are almost in the same kind of department as the adult urologists. So there's some surgeries that we share between our departments. And so when an older child is transitioned, the care is quite seamless, and all of that attentiveness that one would experience in a pediatric setting is carried through. I recently referred a patient on the autistic spectrum disorder to urology and to adult urology at Groote, but through our pediatric urology department, and the experience was just pleasant all around. So yeah, I would like to say that there are some pockets where things are working well. Yeah, but thank you so much for this.
Thank you, Yankel. I just now request Professor Emil to give his few final comments before we say goodbye. Sharif, final comments?
Yeah, I mean, I would agree. I learned really a lot just in the last hour from the other experiences. I guess, you know, like many of the challenges we have in terms of infrastructure and all that, you know, we always say all politics is local. Well, all healthcare is local. So you have to look at your own environment and figure out what really works. But the bottom line is, I think it still is about a particular patient who may not be served well if they don't have the adequate care. And I think that's really where, on a day-to-day basis, in the absence of a perfect world, as Larry just mentioned, we really have to invest. It's not every patient will need this, most will not, but this is about identifying the patient who will really be you know, lost in the crowd and potentially harmed if we don't make sure they're getting the care. And I guess the one thing I would maybe slightly disagree with is the word sever. I don't believe we should sever our relationship with patients regardless of their age, because this is where the advocacy role comes in. And many who may feel lost in the adult world really don't have any other advocate except for us. So we have to be ready to step into the adult world for them and be their advocate.
Thank you very much, Sharif. Thank you all. I mean, we are really honored to have attendees from Montreal, New York, all over South Africa, Northern Ireland, India, some I think are from Pakistan. So we really feel blessed. Next week, Dr. Helga Nahaus, our registrar, will present about gallbladder diseases, including gallstones in children. Dr. Seloma Chaya is going to mentor her, and Professor Martin Funnikirk, one of the most experienced pediatric endoscopic general surgeons in the country, will be our invited guest. So we look forward to seeing most of you back next week. Thank you very much again. Have a good morning, evening, good night, wherever you are. Thank you, Sharif.
Thank you all. Nice to see you all.
Bye-bye.
Bye.